Good afternoon, Professor Gibson. Mr. Duncan.
Thank you, my lord. Professor, can I maybe just go back and have you clarify one matter that I asked you about earlier, and it was about the report by a company called DMA Canyon. Now, in your statement, you indicated that was not something you were aware of at the time.
Not in 2015 or whenever it was commissioned, yeah.
Yeah. And at some point, you subsequently became aware of it, is that right?
I heard of it referred to at the IMTs.
Yeah. But just on the question of who did or did not know about the report and what was in it and what it said about total viable counts or anything else, is that something that you yourself have any direct knowledge of?
Well, I would know who was, I wouldn't be able to name individuals.
No.
My understanding is the report was sent to facilities sent it to microbiology. But I don't know who the individuals, were, and I don't know if it went further afield, than that.
And you don't know...
And I only know that secondhand from the IMTs.
That's really what I was asking. I think that's the critical part.
Yeah.
None of the people in the departments that you've just mentioned are going to be giving evidence in this hearing. So I don't know what their position on those things would be. So is your position that you yourself personally don't know who saw it or when they saw it? I
don't know the individuals who saw it. I only know what was reported at the IMT.
Now, moving on then I want to move on to the decant in September 2018. Now, the way I want to do this again is similarly to try and see if we can, as it were, hasten ourselves through the chronology. And I'm also conscious that there are other witnesses who can provide quite a bit of evidence on this bit of it. If we just start the story again then at round about the beginning of September 2018, and again, I think I'll try and do this the same way. I'm going to ask you just to give a kind of overview, and then I'll maybe ask you about individual bits. But just really to get an idea from you of why there needed to be a decant. What was your broad understanding at the time?
Well, this is my broad understanding. More gram-negatives had been isolated in patients. The view of control of infection was that they were coming from drains. We had already cleaned the drains, we dosed, we had done everything I thought that would clean up a drain, and we still had the problem. So there was contact with an expert drain person, and the view was that there would be more work requiring, which wasn't just about brushing and cleaning and dosing drains, but might be about scoping, drains. And anyway, long and the short of it is that all the remedial things that had to be done would be very difficult to do with the patients still in their rooms and in the ward. So one of the reasons, I'm not saying the only reason, but one of the reasons for moving was to make it possible for that work to be done.
Yeah. Can you remember whether, again, emphasising that we're at the stage of September 2018 and not later, can you remember whether there was any suggestion or discussion around then about a review of ventilation system on the ward?
I remember ventilation systems being spoken about, but I can't honestly remember with any confidence exactly what that discussion was. But the ventilation was discussed because the chill beams, were discussed. And I don't really understand chill beam technology. I'm honest, I never heard of chill beams really until all of this, came about. So there was some discussion around the ventilation in relation to the chill beams.
And again, then, I'm taking my lead from what you've just said about not being an expert on these matters, and just trying, therefore, to look at the sort of broad strokes of this. Are you indicating that among the concerns that was being raised was around...
Well, the drains had been cleaned, and the problem had reoccurred. So we were looking for other sources of water that might be causing the infections. And one of the sources of water was either condensation from there might have been others, but one that was discussed, that was the chill beams, either condensation or leakage from the chill beams.
Thank you. Do you recall over this period whether your fellow clinicians and you were raising concerns that things were no closer to a resolution?
Absolutely.
And
We all felt we were no closer. This was something like the third event we'd had. We'd had the March one, we'd had the June, July one, and now we were into a September issue with infections.
And did you eventually have a meeting with Kevin Hill about that?
We did. We had a meeting ourselves, as I remember rightly. I don't know if you want to show me any minutes, but we did have a meeting of ourselves where we really questioned that we were the safety of the environment, we were no closer to a resolution, despite a lot of remedial, things having been done. And we had a meeting with Kevin Hill about about an option appraisal of what might happen.
Did you feel that you were getting a response from the appropriate level of management on these questions?
I felt, and this was perhaps my feeling and not everybody's, but I think it was, that we had been, by September, we'd started in March, and during that time, we had taken the taps off, we'd pulled them apart, we'd cleaned the straighteners, we'd put filters on, we had replaced the shower heads, we douched or dosed everything with silver peroxide, we then douched it with carbon dioxide, we brushed the drains, we cleaned the drains, we'd done everything. But nothing was stopping whatever was happening. We were no closer to the resolution. So in some ways, I'm not saying I didn't think it was being escalated properly. I didn't think it was, but I was also very concerned that we may not have the expertise around that table, to sort it. I mean, if I had a recurrent medical problem, I would go to who the recognised world authority in the UK is. And I felt that it was time for us to take a step back and just say, stop cleaning the drains and try to really get to the bottom, of what is going on.
Now, against that background and that comment that you've just made, I wonder if you might have before you, if we've come up on the screen, and it's Miss Callaghan this afternoon, I think. If it's bundle 1, please, Miss Callaghan, page 169. Sorry, yeah, 169. Now, this is an IMT of the 17th of September, and we see your name not recorded as one of the attendees. And then do we see below that an explanation? You're not there, and you have provided a statement that Dr. Inkster read. Is that right?
That's correct.
And I wonder, Miss Callaghan, if we could just maybe enlarge the paragraph that begins, there has been another positive blood culture. Yeah, that's fine. Thank you. Thank you. That's perfect. And again, if you just take a moment to read that, the "can you please assure me" bit, I think, is the bit that you will want to read.
Yes, I've read it.
Does that reflect the concern that you've just suggested to us?
I think by this time I felt very frustrated that we weren't getting to the bottom of the problem. It's maybe not to the best. To the best of my memory, we'd had a previous IMT, the minutes of which I would not have seen, because the minutes tended to be tabled just before the next meeting, so I would not have read them. I had heard that I had been phoned that weekend and told we had another blood culture and positive blood culture. At the same time, I'd been told that the executive group had not agreed to the decant or not agreed to that. Now, that turned out not to be true. They had postponed the decision rather than not, but I wouldn't have known that because I hadn't seen the minute. And I just wanted to say, let's just stop and review what we're doing, because what we're doing is not working. There has to be somebody out there who has seen something like this before, who can give her some direction. And I would refer you to later on in that minute where Teresa Inkster talks about contacting somebody called Peter Hoffman, who's meant to be the UK authority on these kind of things, who said exactly the same thing. Stop cleaning your drains and try to get the source of problem. I'm not saying, I mean that metaphorically. Of course, you have to clean the drains if they're infected. But, it was more than just doing that. We had to try and get to the source of the problem.
And just so that we can see that reference for ourselves, Ms. Callaghan, can we turn on to page 171? And it's item 4. I think it's the second paragraph. It doesn't need to be enlarged. That's perfect. Dr. Inkster have you got that, Professor?
Dr. Inkster has spoken to Peter Hoffman, and his opinion is that you should not have to clean drains continuously. And we were cleaning them continuously. The grime would come up every 4 to 6 weeks, and that the underlying issue should be resolved.
Yeah, thank you. And just then to go back to really the paragraph that we were looking at, we don't need to go back to look at it, but just to really tease out what you're saying. Does it really go back to what you said a moment ago, that was your concern that the board didn't have the right people around the table looking at this issue?
Well, I don't know who decides who's round the table. I don't know whose decision that is, if that choice lies with control of infection. It's not so much about not having the right people around the table, because I don't doubt that the people around the table were very good plumbers and facilities and directors. It's just that nobody had seen anything like this before. And surely out there was somebody who had seen something similar like this, who could point us in the right direction, because it doesn't matter what we did, the problem came back.
Thank you. Now, I want to move on a bit, and still in the same period of time, and still on the subject of the decant, I want to ask you some questions around the choice of ward that the children were decanted to and the unit was decanted to. Did the clinicians get any choice as regards that?
We got a choice. We were part of the option appraisal. And I remember going to more than one meeting about the option appraisal. The things that it's in the minutes, it's in my statement. We discussed the possibility of everybody going to 4B. Well, you've already highlighted 4B is the adult transplant unit, for those who might not know that. You already highlighted the problems the adult transplanters had getting into their units. Well, they weren't going to move out and give us all the beds, and that was very understandable. We talked about going to the Beatson, where we knew that the ventilation and everything was fine, but we know paediatric intensive care. We talked about we couldn't go to another ward in the hospital because, as you've already said, the problem was endemic. It wasn't just confined to one ward. And we talked about a portable army type facility in the car park. Well, you don't get that overnight. That takes a lot of planning, and that would have been a long delay. So the only choice was to go to another ward in the Queen Elizabeth. So yes, we were part of the decision that that's what should happen, but we didn't choose the ward. I mean, we're not in a position, to choose the ward. Only somebody who can control adults with some directorship over adult services could ever have agreed to that.
And whether among your colleagues, were there clinicians who had concerns about the particular choice of ward, as far as you can recall?
We didn't actually see that there wasn't an alternative. That was the only ward that could be vacated. I think it was rheumatology, and they went to Gart Naval Site or something like that. We were making choices out of what was the least unacceptable.
Yeah. I wonder if I rephrase the question, perhaps. Can you recall whether anyone had a concern that, and it may not just be about the individual ward, more just the fact that it's the same hospital campus. Did anyone have any concern as to whether the children were just being moved somewhere else where there might still be problems?
That was raised at an IMT. I can remember, I think it was the facilities people who raised it to say you've got the same drains, you've got the same there. My understanding is that the ward was inspected by control of infection and it was passed.
Yeah. Now, just picking up on something you've just said, A number of people in the evidence that has been provided to inquiry have indicated that they had been, or they had understood at some point, that the adult hospital had a separate or different water supply from the children's hospital. Was that something that was ever suggested to you?
No. As we talked about from my record, prior to this, I wouldn't have known where the water came from either the hospital. But my recollection, as we talked about dosing the system with silver hydroxide or whatever it was, that we did know that the maternity hospital and our campus were different tanks because they were both tested, separately. But I think I understood, I'm not sure that was specifically said, where does the water supply from the Queen Elizabeth comes, but I certainly knew we had a different tank from the maternity hospital.
And do you know, or do you recall anyone ever suggesting, just when the options were being looked at, as to where children could be decanted to, was there ever any concern, or was it ever suggested that a decant within the RHC itself would not be suitable because of the concerns about
that was said, that we couldn't decant within the children's hospital, and because of we had the similar water supply.
Thank you. Now, in a moment, I'm going to ask you some questions about the ward that the principal ward that children were decanted to, Ward 6A. But before we get there, I want to just stay with 2018. I mean, because obviously discussions about what was going to happen on Ward 2A and B in relation to the problems continued. And I want to focus on that. Initially, what was your understanding of how long it was going to take before the decant could come to an end?
Well, to the best of my memory, we moved out after the September bank holiday, which was, I think, the 26th of September or something like that. And we were told we'd be back in for Christmas.
And I mean, that obviously isn't what happened. What was it that changed that, as you recall?
Well, I think first of all, one should say that when one talks about the suitability of 6A, we went there with the understanding it would be for a few months. We didn't go there with the understanding it would be for a few years. Sorry, what did you ask?
I asked you what changed from the timescale of back before Christmas.
My understanding is it was the ventilation. There was a problem identified with the ventilation on 2A. And I think, I shouldn't say how serious, but how much work that was going to take to resolve that, changed over time.
Thank you. Now, just in order to better understand that, I wonder if you could have a look at another IMT minute. And in bundle 1, Ms. Callaghan, could we go to page 223? So you have in front of you an IMT minute of the 2nd of November, and again, you're noted as having been present. Is that right?
Yes.
Yeah. Now, Ms. Callaghan, could you take us to page 224? And I'm conscious that people are watching on the big screen. So section 6, could you enlarge that for us, please? That should be fine, I assume. And again, if we just proceed in the way we've done before, Professor, could you read that to yourself and then tell me when you've done it?
Yeah, I've read it.
Yeah. And so the takeaway from that is that...
for some reason, Tom Steele, who was the Director of Estates, as I remember, and Teresa Inkster, in her capacity as Control of Infection, had been looking at the ventilation in Ward 2A. Now, I don't know what prompted that, but they had been. So the ventilation, ideally, for looking after immune-compromised children, should be what you call positive pressure. That means the pressure within the child's room is higher than the pressure in the corridor, so that any particles or infections don't go from the corridor into the child's room. And what that says is, and I think that is what did happen, at the time of the design and the specification, it had been decided to make the rooms neutral to slightly negative. The problem of making rooms neutral to slightly negative is that over time dirt gets into the filters and they don't work as effectively and the pressures become negative, within the rooms.
Thank you.
So I think there was the need to try and address how to make it neutral or positive. My understanding is that later on they then found that a problem with the ducts, but I'm not enough of a ventilation engineer to really understand what that problem was.
Yeah, no, I'll come to that in a minute. But just going back really to questions I asked you some hours ago now, in terms of what you thought had been provided in 2015, can you say whether you had understood the position would be that the non-BMT rooms would have a positive pressure?
What we were told was that they would be built to a standard required for haematology oncology unit. Now, I don't know if the word positive pressure was ever said, to be honest. I think, the reference to negative pressures is about viruses. You don't want viruses to come out, of the room in a positive pressure. But, that's the reason that you might have a negative, room. But no, I was not aware that they had not been positive or neutral.
Thank you. And I think it might be only right to notice, and we've put the minute away, but that we don't need to see it again, that I think it might be only right to notice that Dr. Inkster said there was no evidence that there had been any outbreaks of infection linked to this. Is that?
I think that's fair. I mean, ventilation is about aspergillus. It's not about gram-negative bacteria.
Now, just on the matter that you've just raised about something to do with the ducts, was it your understanding that there was a further issue discovered, something to do with air being recycled from the bathrooms? Is that right?
Yes, into ducts that, I think.
And are you aware of whether any concerns were raised about that, and what sort of concerns?
I don't think there were any clinical concerns raised about that. I think it would just not be what I think would have been standard practice, to have happened. And if they were refurbishing, then there was every reason to correct that at the same time.
Yeah. I mean, did you yourself ever see or hear of an SBAR written in November of 2018, which indicated that this might give rise to the potential for cross-contamination? Is that something?
Never saw that SBAR, no.
Moving then to Ward 6A. And I want to ask you then about some issues arising from the decant. And first thing I want to ask you about is clinical and nursing care challenges. And these are all things that in a variety of ways you deal with in your statement. But if we were to sum up, or rather, if I was to have you sum up the challenges that the move to 6A presented to you, your team, and your colleagues, and your patients and families, what would you say?
They were considerable. First of all, we had come from a ward, an in-ward patient 2A ward, a daycare 2B, and we had to accommodate both wards on one ward. Now, there was no natural break anywhere where you could say that's daycare and this is the ward. So we had flexible rooms all the time. We lost our TCT unit, our Teenage Cancer Trust unit. We lost things like playrooms and, other things that 2A and 2B provided, that because of the restriction in the floor plan that we couldn't, replicate. So I think that was, perhaps bed occupancy or bed space to man a very busy daycare area, as well as a ward, was very challenging. However, I'm just trying to make myself notes of what not to forget to say. We were in an adult hospital. We are what's often referred to as a user service. We use other services as opposed to being a giver, of services. So it's very important that we have good access to intensive care because we have very, very sick children. It's important we've got good access to radiology and because we do a lot of scanning and things like that. And that became very challenging. We were a long way from intensive care. Intensive care was on the first floor of the Children's Hospital. We were on the 6th floor of the Adult Hospital. First of all, should make it clear, when children deteriorate, you should predict their deterioration. We should not have really arrest calls going out and out. That's what happens when you have a heart attack, and that's not what makes children deteriorate. So you try to predict, but if we did have to put a call out, it was very difficult for switchboard to realise that we're calling the paediatric arrest team, to go to a ward in the adult hospital. So, it was difficult to have, we were nervous about having an intensive care support at such a distance from us. It was where we moved children far further to get them to radiology. We had to move them to get to theatres. Our theatres were still on the first floor of the Children's Hospital. So that was quite a significant to go down 5 flights, pass an adult coronary care unit and pass some things that you'd prefer parents didn't have to see, en route to something. We also were dependent on nights on the hospital. We're one of the luckiest departments, and to date, and we have managed to maintain it. We have dedicated resident on-call doctors till 10 o'clock at night, but after that, it is what we call hospital at night. So that's a team of doctors covering all wards with consultant cover from our unit from home. And they were moving considerable distances. They would generally spend most of their time in the emergency department where new cases, were coming in, or the clinical and decision unit. And for them to come across to the Children's Hospital was difficult because they were being very geographically separated from where most of their activity was happening. So, we had concerns about how safe it was, delivering that service. We were exceptionally lucky that we have quite a number of advanced nurse practitioners, and they agreed to cover 10 o'clock to 9 o'clock in the morning. But, that means if they cover 10 o'clock to 9 o'clock in the morning, they can't be there during the day. So it reduced what staffing we had during the day. So it wasn't without a lot of difficulty. We also had the additional problem of the children who were being transplanted were 2 floors down on Ward 4B. And we borrowed negotiable numbers of rooms, but mainly 3 rooms. And our facilities were a desk in a corridor where the nurses would sit and do what they needed to do. And we would just visit, like as you do in a ward round. But there was no resident medic. We didn't have the capacity to have a resident medical presence on 4B, and was dependent on saying you need to come down and do that. If, for example, we were returning donor cells or doing something that somebody had to be there all the time, then we just have to send one down for that duration. But it was much harder than nursing everybody within one unit and looking after everybody medically within one unit. Does that answer the question?
It does, and there's one aspect that I might go back and just tease out a little bit more. In particular, the proximity to paediatric intensive care is something I'd like to ask about. What are the differences, what are the different considerations and specialties that arise in the context of paediatric intensive care that would make it more difficult or perhaps or inappropriate for adult intensive care to be provided? Sorry, that was a terrible question. But
that's a terrible question.
Yes, thank you.
You'd be shot down if you said that.
Yes, indeed. Yeah, thank you. Don't spare me. Are there particular...
intensive care, there is a specialty of paediatric intensive care medicine. So they are primarily, firstly, paediatricians, and secondly, intensive care. Pediatrics starts at birth. Some of these are 3, 4, 5 kilos, and it ends up with teenagers. That doesn't, managing fluid balance, airways, everything that intensive care manages is completely different in children than in adults because of the size and because of the spectrum of ages.
Yeah, thank you. A further thing I would like to ask about is just to maybe get your reflections on some of the evidence that we have.
I should add, it isn't just pediatrics. We call in, you've heard about the toxicities of what we do, so we call in gastroenterology, nephrology, all the ologies, and they all had to come from an adult hospital. And, they came. I'm not saying they didn't come, but it wasn't without more effort than it would have been to walk up and down one flight of stairs.
Yeah. I mean, we've got statement evidence from a number of your colleagues, and some of them will also give oral evidence. But Dr. Ewens, for example, mentions how anxious she was as a result of the patient pathways, as she describes it, especially in the context of
the transplant.
Yes. And she particularly mentions transplant babies.
That is true. They were on an adult ward. There was no no resident medical care overnight, and any problems they had, it was hospital at night that were covering them, and they were a long way from PICU, geographically and distance.
Well, she says geographically and, as it were, temporally, she said it could take at least 5 minutes to get to PICU. Would that be?
That is easy. But, generally, what would happen is PICU would come to us, and PICU would transfer them to PICU. And we were not, sometimes we did, but generally we were not the people transferring them. The idea of you don't move somebody who's unstable. You bring in the team and then you stabilize them, then you move them. But we were still a long way from PICU.
Okay. So if I also maybe ask for your observations on some of the evidence we heard from the patient and family witnesses about the suitability of 6A, I suppose particularly in the context of what you said about it not being a short-term decant. Yeah. I think the overall description from them was that it just wasn't suitable for pediatric hemato-oncology patients.
I think that is probably fair, but there wasn't really an alternative ever proposed. The problem was the length of the decant.
In that context, some of the witnesses painted quite a bleak picture of life on Ward 6A. Some described almost feeling institutionalised on the ward. Is that a picture that you would recognise?
I think two things happened that might have made them feel institutionalised, and I do understand that. Because of the infection, the problems with infections, the IMT would look at what were the possible sources of that infection. So, one was that, people coming in, visitors should be reduced, visiting teams. So instead of 5 gastroenterologists turning up, 4 stood at the door and 1 came in. Normally a consultant would come with their trainees and their senior nurses, but they wouldn't enter the ward. So we tried to restrict the number of people passing through the ward to cut down the infection. So that's one of the things that probably made people feel a bit institutionalised, that they didn't have the normal flow of visitors. And, and that's very important if you're stuck in a room, that somebody comes to relieve you for a bit of time. So I think that's one of the reasons they probably felt like that. But the other thing you have to remember is for a significant, I honestly can't remember the dates. I'm dreadful with dates. But COVID was with us, during the time that we were in 6A. And COVID seriously restricted what could happen. So I'm not saying that it wasn't all about COVID. It was a mixture, but they had, there were 2 reasons that they might have felt institutionalized.
Yeah, well, that allows us to move forward in the chronology a bit, I think, to early 2019, which I suppose is probably about a year before COVID was an issue. And I'm going to have you look at a few IMT minutes from around that time. Now, again, I'm anxious that we do not get into individual patient cases, and I think it's particularly important we tread quite carefully at this stage. So what I'll do is, rather than have you set out your recollection of things, which may or may not take us somewhere where it might not be best to go, I will ask you to look at some IMT minutes, and we can use those to frame the discussion. So if we begin, please, Miss Callaghan, if we can go to bundle 1, and at page 255. You should have a minute of the 7th of January, 2019, and it's another one that you've attended.
Yeah.
And we can stay on that page, and we say if it needs to be enlarged. But below the redaction, we see that hemato-oncology patients are receiving prophylaxis as agreed. The provision of prophylaxis in the paediatric population is problematic and further described below. Now, again, just trying to confine ourselves to really what's said there. There was a return at this stage of the prescribing of additional prophylaxis, is that right?
Looking at the date, I would imagine that was a return of antifungal prophylaxis.
Yeah, that's what I was really about to ask you. I mean, I presume you're familiar with this particular minute.
Yes.
Yeah. And I think you know that there was a concern about a pathogen called Cryptococcus.
Yes.
Is that right? And I think we can see from the minute that sampling in a plant room had found signs of Cryptococcus, and I think it might be important to say that that was not confirmed as being the particular species.
Strain. No, it's a different strain.
Yeah. But what I'm more interested in, if we can move over the page, please, to page 256. And you see at the very top of the page something which I think you've just touched on. Air samples taken on 6A, 4 rooms, have heavy growth of fungus, but no Cryptococcus identified. You see that?
I do.
And then if we drop down the page, I don't think we need it enlarged, to the section beginning hypothesis. And if you just move 2 paragraphs up, where you see N6A and 4C, do you see that?
Yes, I do.
In 6A and 4C, we would expect to see fungus on plates as they are not HEPA-filtered wards. However, 6A seems significantly heavier fungal growth than 4C. The reason for that is unclear. Is that right?
Yes.
And does that accord with your recollection of the concern about fungal growth at the time?
Yes, it does. And if I remember correctly, I think Cryptococcus was grown. And I know initially it just says a heavy growth of fungus, but I think as you say, a different strain was grown.
Yeah, I think so. As you've raised it, I think we'll see when we go through the paperwork that a little later, I think on 6A itself, in fact,
Yes.
Cryptococcus, is it albidans?
I think so,
It was
yes.
found, but not Cryptococcus neoformans.
Yeah.
And if we go over the page, please, to page 257. And Ms. Callaghan, I wonder if we can just enlarge a little the paragraph at the top, the patient prophylaxis one. Thank you, that should be fine. And again, Professor, if you want to just take a moment to read that and then indicate when you've done it.
Do you want me just to read the first 3 lines?
Yes.
Yeah, no, I can read that paragraph.
I don't think the redaction really changes anything.
Okay, I've read that, yes.
Thank you. I mean, does it really speak for itself that there's a
Well, firstly, the first sentence, I'm not sure that that's a correct record of what was said. I would have said that the ambisome, we'd had a number of patients who'd had reactions to the ambisome. I have never given an adult ambisome in my life, so I wouldn't know if they have fewer side effects or not. My recollection is that the adult physicians were involved with some of this because they also had a case, and they probably said we give it with no problem. But, the reason that this was raised was that we'd had one or two children have reactions to the ambisome.
Thank you. And if we pass over the next paragraph, we see, is it Dr. Inkster saying, concerned that patients will now be on 6A for a significantly longer period than first envisaged when the prophylaxis regime was agreed, and there are concerns regarding the safety of the prophylaxis. In addition, air sampling has shown heavy growth of fungus, and 6A is not a HEPA filter ward. You see all of that?
That's which paragraph, sorry, is that?
It's the one that begins
yes,
TI
yes.
concerned.
Yeah.
You just take a moment to look at it.
Yes, I've read that.
Thank you. And does that accord with your recollection of what was being said at the time broadly?
Yes, it does.
Yeah.
But you have to bear in mind, 2A wasn't HEPA filtered either.
Yeah. But I'm not I'm not going to be asking you about the absence of HEPA filtration, to be absolutely clear. I'm more interested in the concern about the use of prophylaxis as a result of a concern.
Well, I think first of all, I should start off by saying we prophylaxed as the hematology oncology team, we prophylaxed when the IMT recommended prophylaxis, and we stopped the prophylaxis when they told us safety measures were in place and we could stop the prophylaxis. All drugs have side effects. And these are, there are a number of drugs you can use against fungus. You can use ambisome, which is our norm for inpatients. You can use any number of drugs belonging to the family of azoles. I think posaconazole is mentioned, or you can use caspofungin. Caspofungin Cryptococcus is not sensitive to caspofungin. So caspofungin, we either had ambisome or an azole. For us, looking after children with leukemia, we give them a lot of vincristine, and you can't combine vincristines with azoles because azoles accentuate the action of vincristines, and there's a risk of seizure activity. So we were limited in what we could use, or it became incredibly complex of giving them 3 days and stopping and starting, to get to have time away from the vincristine. So we tended to use ambisome, but we did see reactions to the ambisome, and I think that's the point I was trying to make there.
Yeah.
That, accepting the risk of the fungus, this wasn't ideal by any means.
Mm-hmm. I mean, just pausing things just now, pausing the chronology just now, I'm thinking about everything that you and your patients and families had been through leading up to a decant, and here you were in the new ward. You're going to be there for longer, and there's now a concern about risk from fungal growth. There's also a concern about cryptococcus, and there's the provision of additional prophylaxis again. I mean, how were you feeling at that point?
Well, by the environment, I think quite frustrated, if I'm honest. We have to take prophylaxis within the setting that we're used to working. We prophylax a lot of children by protocol, but I don't, we were extending the amount of prophylaxis, and we were seeing side effects.
Yeah. I mean, overall, I think we take from this, among other things, that, well, in fact, if we go on, I think it might be captured in another, what I was about to ask might be captured in another page of this minute. If we go to page 258, And if we enlarge the section headed staff, BG will feed back to clinicians at a ward meeting this afternoon. She will inform them that the air sampling results are abnormal and there is a wider fungal problem. And if you were feeding that back to the staff, would it be your expectation that that would also be fed back to patients and families?
Well, they would certainly be told there was why they were getting, antifungal prophylaxis.
Yeah.
Don't know if I would use those words, but we would have said, there's the risk of fungus. There's a risk of fungus, and you're getting antifungal. To be fair, we still prophylax a lot of these children. Yeah. So some of what we did that we're still doing because we recognise the risk of steroids and neutropenia.
Now, I think we can see that, I'll take a step back just to pick up on something you said a moment ago. Were you feeling fairly frustrated by this stage?
Yes.
And did you, at this stage, seek to escalate that to senior management?
I think, if my memory serves me right, I, at this point, wrote to Jennifer Armstrong and I asked her to come, and I think this is the timing. I do have to confess to getting the timing a bit, struggling to remember just exactly the chronology of everything. But at one point I did write to Jennifer Armstrong. I think I told you we had a unit meeting, and I invited her to the unit meeting to come and meet with the clinic. When I say the clinicians, it is a multidisciplinary, meeting to discuss what was going on.
I wonder if we might have a look at what I think is the communication to Jennifer Armstrong. And if we go to bundle 6, please, Ms. Callaghan, page 43. Now, the redaction is once again to reflect a concern about patient identification, and it doesn't change anything. I wonder if, I don't know how easily people can see that. Maybe just enlarge it a little if possible. Thank you.
Well, I think that kind of says what I previously said to you, that we were prophylaxing with ambazome or posaconazole, and we couldn't use vincristine, and that we were seeing toxicities that we were unhappy, that gave us concern, and we wouldn't want to be prophylaxing unnecessarily.
What is a serious anaphylactic reaction?
Children who got ambazome and perhaps wheezed or got swollen lips or had some kind of allergic reaction to the ambazome.
And if we go to the paragraph that begins securing the safety of our environment, requires action across the directorates. I would just refer you to the conclusion of that paragraph, which say promised statements from the press office have not materialised. We are prophylaxing children without any agreement on what information should be given.
Well, if I remember rightly, this meeting was the 7th of January. A number of actions had been discussed prior to Christmas, and I think in this I'm saying they hadn't all delivered, and that they involved not just paediatrics, but if there were laboratory things, they involved the laboratory directorate. Estates was a different directorate. And I was asking her, as somebody at board level who could cover all directorates, what she was going to do about it.
What did you mean by it is hard to believe that the gravity of this situation is really appreciated by those charged with resolving it?
I think I mean exactly what is said. If I did feel if the gravity of the situation was appreciated, then things would have been done as they at the time over the time period. Christmas would not have mattered. States would have acted, the laboratories would have acted, and we'd have been closer to some resolution.
And when you're thinking about those charged with resolving it, which level of the board? Ultimately,
the board is charged with resolving it. They can delegate things down, but ultimately the board is charged. And if they can't do it, they are charged with making sure that those they delegate to do it.
And when you refer to the board, are you also referring to its executive management team?
Yes.
And when you say
I probably am referring to I don't really know who the executive management team is.
the chief executive.
Yes, yes.
And you, as you've said, you mentioned the unit meeting and ask if Jennifer Armstrong would be willing to use this as an opportunity to meet with us. If you're not the appropriate person at the board, please let me know who is. I mean, who did meet with you after this?
Well, my recollection, it was Marion Bain, who I think became her deputy for control of infection or something. There will be a minute from that meeting. I just don't have it.
It was, at the time, was she senior or junior to Jennifer Armstrong?
Junior.
Did you receive any response from, for example, the chief executive in relation to this?
No.
Did I take you a moment ago to indicate that your frustration was directed at that sort of level?
Are you asking me, was my frustration directed at a senior management level, stroke executive committee?
Yes.
Yes.
And what was your frustration?
That nothing had resolved. That we were seeing one problem after another related to the environment.
But what was the frustration that you directed particularly at that level of management?
I'm not sure I understand that.
What is it you think that, what is it that you thought that they were not doing?
Resolving the problem.
What was it they were saying to you?
Well, I was asked, we were expecting them to deliver a safe environment for treating children.
Did you feel that you were getting an explanation from that level of management as to what they were doing?
No, but I don't know what they were doing. I mean, they could have been having a 6 o'clock in the morning meeting every day for all I knew. I had no contact with senior management other than occasional contact with Jennifer Armstrong.
Was this an email intended to indicate that as the lead clinician for this most vulnerable group of children, you considered that there needed to be a communication from that sort of level?
Well, as the lead clinician for the most vulnerable group of children, I wanted told somebody responsible for making sure that actions which had been promised were delivered.
Do you consider that you got an adequate response to this email?
No.
Now, moving on slightly from there, I want to ask you a bit about the communication of matters with patients and families at that time. It goes back really to something we discussed earlier. At what level of seniority in management did you understand communications to be handled at this time or controlled?
From what I saw, the communication from management came from the local. The face-to-face communication with parents came from local management, so from Jamie Redfern, and at that level.
Where did you understand, if you did understand, where did you understand the direction of that messaging to be coming from?
I presume it came from Kevin Hill, the director, and down from the directors at the board.
I wonder if you might have a look at another document. It's in Bundle 5, Ms. Callahan, and it's at page 170. Now, if we just enlarge that a bit, please, so people watching on the big screen can see it. It's yeah. So we've got an email from Jennifer Rogers to you saying, this is the final brief for the families as agreed by the exec team. Who are the exec team?
I don't know who the executive team are, but they will be at board level or certainly above local management level.
I mean, are we talking at the level of the chief executive and the board as you would understand it?
Well, I'd understand that, but I honestly don't know who's an executive.
And
I think directorship level at least, yeah.
If we go over the page to page 172, please. And we'll just walk through this. It's our priority to ensure a safe environment, and so on. There is a review of 2 isolated cases of an unusual fungal infection. There's then the reference to the extra precaution HEPA filters, and it then says, as an additional measure, those children most at risk were and continue to be given prophylactic antifungal medication. We continue to monitor the air quality regularly within the unit, and these results are being analysed by our experts. Do you see all of that?
Yes.
In thinking about what we've just seen, the discussions around prophylaxis, the concern about high fungal counts. I mean, do you think that this was or was not adequate messaging to parents?
I think with time, the information that went to parents improved, and I think this is reasonable, a reasonable statement to make to parents, yes.
I don't think it says anything about high fungal counts. I mean, maybe we don't know enough about what the fungal counts were at that point.
Yes, and you can't tell people what you don't know.
Yeah, but we certainly could see from 5 days before or a week before that there had been reports of that. Do you think that's something that ought to have been contained within this?
Well, you are having a balance of being as honest as you possibly can and not scaring people unnecessarily. I think probably the families knew what you looked at the air quality for. Yes, you could easily argue that something should have been put in there about the fungal counts. Gosh, by the 13th of January, everybody knew. Yeah. What the problem about the problem with the air. Almost everybody anywhere in the world knew, never mind these families.
Yeah. I mean, I think does it go back to something that you spoke about earlier, that the fact of the matter is that communication with these families would have been happening all the time with clinical staff.
They would have asked staff what that meant.
Yeah.
If they'd any doubt.
And your expectation would be that a candid account of what was going on would have been given.
I don't think anybody ever lied to anybody.
Now, just to, we can put that to one side. Ms. Callaghan, thank you. Just to continue with the chronology then, and to pick up on something you said earlier, we don't need to turn this up. It's my understanding that, the IMTs indicate that Cryptococcus albidans, if that's what it's called, was indeed found within 6A around about the 16th of January. And there's then another one I would like to just have you look at, just to maybe help me with a detail. And it's on the 18th of January. It's again in bundle 1, and it's at page 274. And I think we've got an IMT meeting again, the 18th of January 2019. Is that right? You see that, Professor?
Yes, yes.
And again, I think you're an attendee.
Yes.
I just want to have you help me with one reference in it, and it's at page 276. And it's under the heading press.
Mm-hmm.
I don't know if it's, thank you. A press release has been drafted which will be checked for accuracy before being sent to the executive group for final approval. Some members of this group may not all agree with the press statement. but not everyone across the multidisciplinary colleagues who attend NTs will. So it's about getting the balance correct. I mean, I quite appreciate that it's perhaps even impossible, if not challenging, certainly challenging, to have a discussion about that without having the press statement in front of us. But do you have any recollection of that discussion or what it might be about?
I imagine it's about the cryptococcus, but I don't remember. I don't know the detail of the press statement.
Do you have any recollection of disagreement at an IMT about what went into or didn't go into press statements?
I'm not sure that we had input to the press statements, if I'm honest. I think the press statements were drafted by comms and went to a higher level than us. I mean, that was one complaint of the IMT, that the statement should have come from the IMT. So I don't know that I would have seen this press statement.
Thank you. Now we can put that to one side. Now I want to move on a little in time and deal with the period when the unit was the subject of a further decant briefly at the beginning of January. Yes. Now I think we can see from the papers that we've got that the unit appears to have been decanted to something known as the CDU between the 22nd of January and the 8th of February 2019.
Yes.
Now, I'm going to ask you a bit about what the CDU is in a minute, but before we do that, what was it that led to a requirement for a further move?
My understanding that it was the finding of mold in some of the bathrooms.
Yeah. And are you able to say a little bit more about that, about what that was, what that was about?
I can't remember which mold it was. Most of them are mucors. I don't know is the answer to that. But they were found in the bathrooms, presumably from leakage of water somewhere.
In any event, the investigation appeared to reveal some issue with mould.
Yes.
And that led to advice that the unit had to be moved out again. Is that right?
Well, the remedial work required that the unit moved again.
Yeah. And thinking about this stage of things again, I mean, what was your reaction to discovering this?
I think the same reaction as we'd had to every other discovery, that this was just something else that had been found. And was it ever going to end?
And thinking back to the exchange that we just had about the beginning of January 2019, and whether you felt you got an adequate response from the most senior level, did you feel that this was again something that engaged that kind of requirement for a response at the highest level?
No, I think consistently there are responses came from our local information we got came from our local management.
Yeah, and
to staff.
And just when we're speaking about them, do you mean Jennifer Rogers and Jamie Redfern?
Yes, yes.
And what was your assessment of how they managed communication over the period that we've been speaking about?
Do you mean with the families?
Yeah. Yeah.
I think they did their best. You know, they came, usually the three of us stayed on a Friday and went around to parents with whatever was the handout from after the IMTs. I think they tried to engage well in that.
Yeah. I mean, did you feel at this stage that there would be an advantage in the patients and families hearing from somebody in management at a more senior level than that?
Yes, I think I would go further and say there'd be an advantage in the staff hearing from somebody at a more senior level.
And did that happen?
No.
I want to ask you a bit about the effect of the decant. What is the CDU?
The Clinical Decisions Unit. So it's perhaps for it's like an emergency department. but perhaps for children who are a bit sicker that might come in and they decide if they are being transferred to a ward as an inpatient.
And I think you've already answered the next question. This is in the Children's Hospital, is it?
Yes, it's on the ground floor of the Children's Hospital, yes.
What, if any, concerns did patients or staff have about a decant back to the Children's Hospital?
Well, I think as before, there's a sense of disbelief that this has happened again, and people are very anxious. And it does query the fabric of the building. By and large, the families were pretty good at accepting what we said to them and allowing things to happen. I think whatever has been said, I think they felt that we were acting in their, at least the clinical staff were acting in their best interests. And we did try to explain to them why it had to happen. Quite a lot of the families were actually builders. They could see the mold. They could tell us what was, or they could tell someone like me what was going on. And we explained to them that this was the safest thing to do. And if it was the safest thing to do, they were accepting of it.
I'm just thinking back to the discussion that there had been in September 2018, in which the IMT had concluded that the Children's Hospital was not a safe alternative. And I wonder whether, against that background, there was a concern about going there, or are you indicating that there wasn't an alternative?
To going to 6A?
To going back to CDU in the Children's Hospital?
Which was the only place we could go to, because it was the only place you could decant that group of patients. They were decanted to elsewhere in the Children's Hospital, and that's the only place we had cubicles and beds. To be fair, things like point of care filters were put on, and it was cleaned, and everything else that would make it as safe as possible was done and inspected before we moved. So precautions were taken, or lessons were learned from 2A, and it was well cleaned. I think it was HPV'd, I honestly can't remember, but as much as possible could be done to make it as safe a place as possible, and there was nowhere else we could go.
But just thinking about what you said at the very outset about whose responsibility it is to provide an environment, just on what you said about whatever provision was made about trying to ensure that CDU is as safe as it could be, that wouldn't be something that would sit within your sphere of responsibility, would it?
Not if it's about the environment. Yeah. I can't clean the drains or put on the filters. That's for control of infection, to say what was necessary after an inspection, and for estates and facilities to do it.
Yeah, and what I'm really working up to is saying any assessment around whether it was or wasn't safest to go there would be a matter for others to make a judgment on, not for the clinicians.
Yes.
Yeah. In any event, the unit was moved back to 6A round about the beginning of February, 8th of February 2019, or something of that nature. Can you remember on what basis it was declared that it was okay to go back?
Well, I can't, but it was again about control measures being in place, and I can't remember everything that had to be done. I think something had happened to the drains, and the mould was fixed. We put HEPA filters into the bedrooms. At some point, we put HEPA filters into the bathrooms. So it was about and they were sampled. And with the installation of the HEPA filters, the fungus wasn't grown. So it was about after showing that air sampling showed it to be safe, and the water, nothing was grown from the tap, from the post filter, the water post filter grew nothing, and HEPA filters were in place, and all control measures that could be taken had been taken, and it suggested it was safe.
Thank you. Now I want to move forward in time to the summer of 2019. Patients and families, the unit is still on 6A at that point, and 4B, I suppose. And again, I'll try and take things in fairly broad strokes, but I wonder if you could just set out your recollection of what you recall of a return of a concern about infections in the summer of 2019.
Well, in summer of, as I remember it, there were more patients with, there were further gram-negative bacteremias. I think the number rose to, I don't know what it peaked at, but I can see from my notes, one stage there were 12. Some of them were definitely hospital-acquired. Some were questionably hospital-acquired or could have been acquired somewhere else. But that again raised concerns. And I think, again, the question of whether it was the drains arose. And this time, I think it was the chill beams, in fact.
And again, I'll try and do what I did before and just set out what I have taken from the IMTs. And I emphasise again, I'm only taking what I take to have been said. Whether the events described happened or didn't happen is for another time. There seems to have been a return of gram-negative bacteremia in the summer of 2019, is that right?
That is true.
Yeah. And actually, that's a word we've not used before. Bacteremia. What are bacteremia?
Like septicemia. Or bacteremia means you can culture the bacteria from the bloodstream.
Yeah. Would it be better to say there's been a return of infections in the summer of 2019?
Yeah. I mean, it's always been bacteremias when we've talked about the patients, yes.
Mm-hmm. But I think it's something that we touched on earlier in your evidence. I think there was also another case of Mycobacterium colonae, is that right?
Yes.
And you indicate in your statement that advice from microbiology at the time was that this was likely to have been caused by access to unfiltered water in the hospital.
Yes.
And for anyone wanting a reference, that's paragraph 250. Do you have a recollection, and we did touch on this earlier, of a discussion around a patient having had the same or similar the previous year?
Yes, I do.
Yeah. Now, in his evidence, Dr. Sastry says that he believed that the earlier infection must have come from the environment, and that it is his recollection that he asked for sampling. This is in 2018.
Yes.
He asked for sampling to be done and was told that it was not standard practice to sample for this organism in 2018. Do you have any recollection of that?
I don't have any recollection of the detail, but I do remember there was a lot of discussion around it.
If not a recollection of the detail, do you have a recollection of the broad description that I've just said?
I think so, yes.
Now, as far as staff concerns at this stage, and again at the risk of repetition, what were the staff concerns at this point in the summer of 2019?
Well, there was a recurrence of gram-negative organisms and infections. I think this time it was harder to know if they were above the expected background rate or not. And as you go through the IMTs, you can see that that is questioned several times. And that's a difficult decision to make or to have any certainty over. They weren't all definitely hospital acquired. Some of them might have been acquired outside in the community or somewhere else. But my recollection was that there was another spike is the wrong word because we don't know if there really was an increase, but we were seeing a reemergence, of infections. And we had to balance that with the fact that we will always have infections in our unit. And was it more than expected or not? Was hard to know.
I mean, it goes back really to the discussion at the very outset of this, where I think you indicated that you do have experience that would, as clinicians, that would allow you to form a judgment on whether something was or was not an unusual pattern. But I take you to say you would not go the distance of saying I've got the expertise to say whether that's correct or not.
Yes.
Yeah.
And I think what was always here was the question of the pattern of the infections rather than the number.
And by the pattern, do you mean the clustering, or do you mean the type?
The type.
Yeah. Again, Dr. Sastry, I'll give him another name check at this stage. In his evidence, he says that in 25 years, you would expect to see one or two of the organisms we see mentioned in the IMTs in a single year.
I don't know if that's true or not. I'm not challenging it. I suppose I'm looking after a much more vulnerable population than him, because he's looking after solid tumours. That's possible. We could look back and know, but that's certainly more than we saw.
But again, even if it's true, you would say that there's a limit to what you as clinicians can say about that.
Yes, there is.
Now, just to then think about some of the evidence that we had from the patients and families, at least I think it may just have been two families suggested discussions with clinicians around this time around whether or not it might be safer to recuperate or be at home. Do you recall anything like that?
I think I know what you are talking about. I mean, I think, well, maybe I'm remembering wrongly, but there were some families that came from out with Glasgow that could have had more of their care done locally. And we thought it might be better that that's what happened.
Mm-hmm. And there was a description from parents that by this stage they were close to breaking point. And to be fair, a number of them described that as regards earlier stages. I mean, is that what you saw?
Yes, I think the staff were close to breaking point too.
Yeah. And in that context, I think we can see from the IMTs that there was a meeting at the beginning of August among clinicians, and one of the IMT records the staff as having concluded at that meeting that their concern was that the control measures were not working. Is that your recollection of things? Your recollection of the concern, at least?
Yes, and that there was no resolution and we hadn't really got to the bottom of what the problem was.
Yeah. Now, I'm going to ask you some questions about the IMTs that took place in the latter part of the summer. So I'm thinking about August in particular. Now, again, I'm going to try and tread warily here and would encourage you to do so as well. None of the people, none of the microbiologists or infection prevention control people, and in particular none of the chairs of the IMTs are witnesses or due to give evidence in this hearing. And I think we need to be careful about saying anything that they might consider required a right of reply. But if we were able to just take things broadly, I think you describe in your statement that there was a change of emphasis at some stage in the IMTs in August. Are you able to say a little bit more about that?
Well, I can't remember the dates, but there was a change of chair. I don't know when that happened. Teresa Ingster was replaced with, guess who it was, right, Dr. Crichton, I can't remember her first name. And I think there was a change of emphasis. I think they felt that the emphasis was changed to the environment being much safer. I think at that time, she took a view that the control measures were in place, that everything was fine, and that the environment was controlled.
in your statement, you don't need to turn it up, but for those who want to, it's at paragraph 227. You say there was a change of evidence to one of positivity. What do you mean by that?
Well, I think we were always told what a great job we were all doing and that the environment was good and there was no reason to have any concern about it. There was a lot of data presented about risk rates of infections and York Hill and whether or not these were really any different from what we had seen since the move.
Yeah. Again, without trying to personalise any of this, Dr. Sastry in his statement says of the IMTs after the change in chair that the emphasis changed to being about disproving whether there was.
I think, yeah.
Would you agree with that?
Yes, I think so. That's perhaps what I meant by positivity.
Yeah, it did. So disproving a link to the environment.
Where previously we'd always looked for a link.
Yeah. He, in his statement, describes frustration, feeling demoralised, and an intimidating atmosphere. Is that anything that you would recognise?
Demoralised, yes. I'm not easy to intimidate. So I didn't feel particularly intimidated, but yes, certainly we felt demoralised, and we did feel that we were being, actually intimidation is probably quite a good word. Maybe it's a bit strong.
But if we move from the handling of the concern back to the concern, was it that as clinicians you still had the concern about the pattern of infections?
We still had the concern about the pattern of infections, and we still had then and still have now. We still don't know what really happened, and whether there really was a problem with the environment or there wasn't a problem with the environment. I still think we still are confused about what the real issue was.
And against that background, I think we're right in understanding that at the end of August, I don't mean just you and your clinical colleagues wrote to the Chief Executive, is that right?
We did.
And I wonder if we could go to bundle 6, please, Ms. Callahan, to page 1416. And I wonder if we just enlarge the section from Dear Jane and Jennifer. Thank you. So this is a letter to the Chief Executive and to Dr. Armstrong, is that right?
That's correct.
We, the clinicians of the Hematology Oncology Unit, wish to express our concerns about the infection and environmental issues which have affected our unit, and as a consequence, our immunocompromised patients for the past 18 months. We then see, you say, we seek management's view on the safety appropriateness of the environment in which our patients are being treated. A recurrent theme of recent IMTs has been questioning of the magnitude and clinical significance of recently documented infections with environmental organisms. Control measures instituted previously have reduced the number of positive blood cultures, but those that remain are due to rare environmental organisms, highlighting concerns about the safety of the hospital environment. Now, just pausing there, again, was that the point? It's not about the numbers, it's about the nature of the infections?
I think it's about both, but it's hard to interpret the numbers. But the nature of the infections was probably the predominant issue. And I think that's really what I'm saying about they became more positive. We're questioning of the magnitude and questioning of the clinical significance.
And then you say in the next paragraph, it is of concern that no definite source of these unusual infections has been identified, and so on. And then in the next sentence, some of those control measures, including additional antibiotic and antifungal prophylaxis, have caused toxicities to patients. And is that what you were describing to us earlier regarding reactions?
Yes. Well, depending on what drug you use, the toxicities are different. I mean, I described the reactions to ambisome, but the patients were getting diarrhea and nausea with the ciprofloxacin. They were getting other problems with azoles. Every drug has a different spectrum of side effects.
Mm-hmm. The absence of a confirmed source of these problems means that there is uncertainty that the control measures are adequate, and hence it is difficult to reassure patients, family and staff of the safety of the environment. And if we then just go to the next page. At a recent IMT, it was agreed that an external review would be essential, and we would very much support this. The review should be led by an individual from out with Scotland who is a recognised paediatric control of infection expert. Now, again, you may feel it's self-evident what that is indicating, but it would be helpful to have you explain a bit about what the external review you wanted would be about, why it is you wanted it, and what sort of person you wanted to do it.
Well, I think at this stage, we predominantly wanted, because there was at the IMTs, a lot of alluding to whether there really was a problem or there wasn't a problem. I think that was primarily what we wanted, an external expert to come and tell us what the chances of what we had seen happening by chance or by natural variation, might be. We wanted recognition, had we really been dealing with a problem or not? I don't know that a paediatric control expert might have been the person who could have told us what the problem was. That might have taken somebody with some ventilation or water expertise. But I think what we're really questioning is whether or not there's a recognition there was a problem.
And what was the response to the letter, as far as you can recall?
I can't remember, to be honest. I don't think I've ever seen there must have been a response, but I don't remember seeing it.
Was the external review undertaken to your knowledge?
There have been reviews, but I don't think there was one taken at this time that I'm aware of.
Well, was the external review that you were asking
No.
senior management to instruct, was that done?
No.
Now, I think we know from the IMTs and other meetings that discussions around the question of whether or not...
I need to go back and say something about that, because that's maybe not strictly true. You will know we had a clinical review, a clinical case review. So that was done, but I don't think that's what we meant by review of an expert paediatric control of infection person.
Yeah, I mean, the clinical case review that you're talking about, that wasn't instructed by the...
It was instructed by the government.
Yeah. And that arose as a result of the concerns.
Yes.
And the special measures to use
Yeah.
Now, we can see from the IMTs, and I'm not going to take you through these, that you and colleagues continued to express a concern that you didn't have an explanation for why there had been this concerning pattern of infections again. Is that right?
That's true, yes.
Yeah. Now, I am going to spend more time on that matter with some of your colleagues, because I think some of them were at IMTs about this that you were not at. Is that right?
That's possible.
Yeah. Dr. Chowdhury and Dr. Murphy in particular were at a number of them. But what's your broad understanding or broad recollection of what happened over that period leading up to the reopening of the ward?
The reopening of which ward?
Of 6A. Sorry, I need to take a step back. One of the things that we've passed over is it correct that over this period there had been a restriction on the admission of patients to Ward 6A because of these concerns?
Intermittently there had been, and that was either done because of concerns of infection, or it was done because works were ongoing and there weren't enough beds. There wasn't... we didn't have enough bed capacity. Yeah. So yes, we did intermittently restrict admissions and send patients to Aberdeen or Edinburgh.
Yeah. Now, we can see from the papers that we have, that there was a meeting on the 11th of November 2019 at which agreement from clinicians, I think, that the ward could open up again was reached. Now, you don't appear to have been at that meeting.
I was in India.
Yeah. What was your understanding of the of where the assessment came from that it was safe to lift whatever restriction there had been?
Well, I wasn't at the meeting, so I don't know. I think the assessment came from control measures having been carried out, and the view that we hadn't seen any recent infections. But I don't know for certain. I don't know what was said at that meeting.
Mm-hmm. But to what extent does it go back to the discussions that, or the approach that was taken in the IMTs in August that you spoke about earlier? Can you recall whether the advice that was coming from infection control people within the board was that they were satisfied that there was no issue?
Yes, yes.
Now, I want to ask you about one further document before we move towards concluding your evidence, and it's in bundle 6. That's at page 10. And I wonder if we might just enlarge that a little, please. Thank you. Now, before the top disappeared, Professor Gibson, were you able to see that that was an S-bar?
Yes, I was, yes.
Is that something you've seen before?
Not before this inquiry.
Yeah. If I help you with the background to it, a clinician from a clinician external to GGC from another health board was asked to do a review of prescribing of prophylaxis, and in particular, I think around the communication in relation to that, and that he was asked to do that by the oversight board. That was part of the measures that were put in place by the Scottish Government. And I really only want to ask you to help me with a couple of bits that he in the SBAR that he wrote. But before I do that, do you recall any meetings or discussions with him? Mr. Andrew Murray?
No, I don't recall meeting with him about discussing the prescribing of within the unit at all. I think I met him when he was first appointed as the chair of the MSN, but I certainly didn't meet with him over this topic.
If we just go to the paragraph that's fourth paragraph down or fifth paragraph down, hemato-oncologists have provided. Have you seen that?
Yeah, I see that, yes.
Hemato-oncologists have provided confirmation that they are reassured regarding the safety of the water and improvement in 6A based on evidence from a range of sources and the long-standing improvement approach to infection control. Did you say that to him?
Personally not, no. I mean, I don't think I didn't meet him at this time. I have no recollection of having met him.
Do you know where that...
No, I don't know where that statement came from. I think we had moved back into 6A and accepted the current control of infection view that it was now safe. And after all, although we say that providing a safe environment is the job of the board, the deciding if an area is safe to give that treatment is the responsibility of control of infection.
Would you take any issue with what's said there? And I mean, it seems to set out the position of the hemato-oncologists, and you're saying it doesn't come from anything that you said to Mr. Murray. But do you take any issue with what is said as regards your position?
I don't know the date of this. What is the date of this?
It's December 2019.
trying to think what that. I think we had moved back in by then.
Yeah.
So he's presumably assumed that we were happy with the safety, or we wouldn't have moved back in.
He seems to be going a bit further than that. He's saying hemato-oncologists have provided confirmation that they are reassured.
Well, I don't remember ever meeting with him.
Okay. And you don't remember being asked to or providing the confirmation either directly or indirectly to him that you were reassured?
I don't remember.
Thank you. Now we can put that to one side. Just trying to pull all of this together, Professor Gibson. And thinking of the story that you've set out to us today, and that the patients and families also set out, how would you assess the impact of all of the events that you've described on families overall?
Well, I think, they have told you the impact it's had on them. I think it's been considerable. It's been one of fear in terms of infection, but it's also been one of fear in terms of all the remedial works they saw in their questioning about the safety of the environment that their children were being treated in. So, I think it's had a big impact on them. Has it had if we look at the current patients going through, I think the current patients going through the new unit is much better. I think they're happy with the environment. And I think trust. I do feel that the current patients trust us.
Just on that point, on the issue of trust, and it's important to hear from you on this. We've stopped the chronology at 2019. It's now 2023. Now, accepting that you and your patients have been through COVID in between, have you seen in the period since 2019 a return to any of the concerns about infections that you had seen before?
No, I don't think I have. However, just the concerns or everything else was reiterated last year when the parents gave evidence, and I'm sure the same will happen when the clinicians give evidence this week. So some families will relive it. There is no doubt about that. But I think, I don't think actually trust for the clinicians was ever lost. And I think it is certainly there now.
What was the impact on you and on your colleagues of all of this?
Some people have described themselves as destroyed. It was significant. You can't reassure or tell somebody not to worry about something if you don't know what the root cause is or what the problem truly is. So it was very difficult trying to be reassuring and honest and supportive at the same time. And I think as a team, we did question what we were doing all of the time. Was it right what we were doing? But we did all of this in the background of actually being told on one hand there was a problem, and on one hand there was no problem. And that certainly compounded how difficult it was to deal with this. But, there was enormous amount of stress around staff, staff who went to their unions, staff who didn't want to come to work. I've never seen a toll taken on staff like it, and old enough now that I won't ever see it again. But it was very, very considerable. I'm not, one has to recognise that the biggest toll was taken by the parents, and I would never want to say anything that sounded as if I didn't recognise that, because I do. But this is about the strain on some of the, particularly the nursing staff, was huge.
Something that you, I think, touched on a moment ago, and in your statement, just on this question of trust, you say you indicated, you say that you think there's been no loss of trust in the clinical staff. And certainly, I think most people would say that's what they took also from the patient and family evidence. But in your statement, you do indicate that there may have been a loss of trust in the hospital environment.
Yes.
And are you concerned that that issue remains unresolved?
Well, I'm concerned the issue remains unresolved, but if you're asking me, am I concerned about the current unit we're in, I'm not concerned about that. The families who are in it seem very happy with the environment. We'll never make it perfect unless we can make it twice the size it is, and that's never going to happen. But, we're talking about safety, here.
Are you concerned, just picking up on something you said a moment ago, are you concerned that the inevitable attention that this hearing will get may give rise to current concerns about the building, about the hospital?
Yes, I think we have to acknowledge that any child going through treatment now, if they get an infection or a gram-negative bacteremia, the family are going to think that it's the environment that's caused it, even if it is not.
What could be done, do you think, to try and address that concern?
I think we just have to try to explain to the families that that's not the case, where we think the infection came from. Perhaps, I don't really know what happens, but I think there might have been some merit in telling the families going through at the moment that this was happening and pre-warning them, so that they weren't, and I'm not sure that happened. But I think something might have been put on the Facebook page. We did ask for that to happen, because I think they're better to be pre-warned than turn on the news.
Do you think a clear account of what did happen might assist?
Well, it's quite hard to give a clear account of what did happen, because it was so complex. It's not a one-sentence job.
We have seen in your evidence that on a number of occasions you sought an account at the most senior level of management in the health board. Do you ever feel that you got an explanation?
I still don't know. That there's two versions of what's happened. There is a real environmental problem and there's no environmental problem at all. I still don't know which is true. All I can say is that we have had a £11 million refurbishment, and we now have what is said to be the best ventilation system that money can buy, and we have got water that is coming out of a post-filter tap, which has no bacteria in it.
Yeah, you've told us about the debate in late 2019 about what the cause was, but your evidence started in 2015, and you told us about concerns about the transplant unit at that time and the escalation of concerns at senior level. You told us about concerns in 2018, the beginning of 2018, and later in 2018, and further concerns in 2018. You told us about advice that there was an issue with the water, there was an issue with drainage. You've told us about the issues that then arose at the beginning of 2019, a further decant to another ward. And you've also shown us that throughout that period, from time to time, you, as the lead clinician, sought an answer, but at the very highest level. And I ask the question again, do you ever feel you've had that?
No.
I want to try and I know you also want to try and finish your evidence on a more positive note. And I wonder if we can start to think about the future as the future for the Schiehallion unit as you might see it. What do you think that looks like from your perspective?
Well, we have to, one of the things that I personally found hardest was the loss of reputation. We are well known nationally for this problem that we've had, and that's not how you want to be recognised. I think all we can do is move forward as positively as we can. I think we're a very strong team. We're a multidisciplinary team. We're inclusive, and I think we just have to move forward. We provide quite a lot for Scotland that nowhere else in Scotland does. We have the National Bone Marrow Transplant Unit. We have the Minimal Residual Disease Laboratory. We have the Early Phase Trials Unit. So, we provide a lot that isn't provided elsewhere in any of the other centres in Scotland, and we just have to develop on that.
I wonder, Professor, I'll give you the opportunity to offer any further reflections that you want to offer, but I wonder if it might be important to have a look at something that's in your statement. It's at the very end of your statement. Ms. Callaghan, could we have up on screen page 69 of the statements bundle, and in particular paragraph 295. It's Professor Gibson's statement. It's page 69 of the statement bundle, sorry. And it's paragraph 295. I don't know what you want to do, whether you want us just to read it or...
You read it.
I know, I think you should read it, if anyone's going to read it.
Oh, I can't read it.
Yeah, well, I'm pretty sure I can't, so...
Okay, I'll read it. So here goes. As difficult and as unbearable as the last 3.5 years has been, as a multidisciplinary team, we all recognise that we're privileged to look after this group of children and engage with their families at the worst time in their lives. I chose to name Schiehallion for our unit to symbolise the uphill struggle these families face. We are now back in our refurbished unit, and this summer we'll climb a mountain as we did in other years before this problem. Those who can walk up the steep but broad path will do so with staff, families and friends, and those who can't will spend the day in the field at the bottom, catching tadpoles in the stream, having their faces painted, having a massage, or toasting marshmallows on a bonfire, because that's what we're about.
Thank you. Just one point of detail on that. I mean, the metaphor in that, intended or otherwise, is obvious and incredibly moving. But am I also right in thinking that the unit does actually go hill walking?
Yes. Well, we don't all walk up. You walk up if you can walk. It's not an easy Monroe. I've walked up about 5 times with the unit. Jerem's walked once. And we take the children who come up with their parents and the brothers and sisters, and they walk if they can, and the younger ones sit at the bottom in a field.
Thank you.
And play.
Professor Gibson, I've got no further questions for you. Is there anything you want to add to what you've said?
Well, I shouldn't, but I will. For all of how awful this has been, I do think we are a great team. I built the unit, and I'm very proud of each and every one of them who's worked in it and has survived this. As Churchill said, when you find yourself walking in hell, keep walking, and that's what we did. We did our best. And we just want everybody to appreciate that we did do our best and that we did try endlessly to bring attention to the concerns we had to those above us.
Thank you. That would conclude the questions I have, my Lord.
Thank you, Mr. Duncan. I have to confess, Professor Gibson, when I first read your statement, I thought that was a metaphor.
Oh, no, it's real.
I read your statement again. It occurred to me that, given the detail, it might just be true. or rather not metaphorical, an actual statement. And I thought it was a strong metaphor, but I thought it was even stronger as a statement of fact. Now, I'm slightly embarrassed because I'm going to ask two terribly detailed questions, which really don't measure up to the power of that statement. One is in relation to what, and I don't require detail, it's just that I get a slightly better understanding. Datex, which I take to be a digital...
Something like that, yes.
Yes.
I can send you that.
My question is, I think you made the point that in relation to information about infection, it's really the laboratory that tells you rather than
Yes, well,
that you tell the laboratory, because presumably
they're first detected in the laboratory, so the laboratory tell us.
yeah.
We may ask the laboratory for more information, but they tell us what the organism is. And they will then tell us the sensitivities.
Right, and is Datex a means of communicating that information, or is it something different?
No, Datex is an electronic way of reporting any incidences.
Of
Reporting any incidents. So if chemotherapy was delayed, or if there was a spillage or anything like that, that's the type of thing you do on Datex.
And the reporting is, well, if it's any sort of incident, can anyone use Datex to...
Oh, anyone can put in a Datex.
Right.
And then they are reviewed. We review them. We review the transplant ones. We have a transplant quality management meeting. So we'll review any related to transplant at that. And for the rest of the unit, they'll be reviewed at the clinical governance meeting.
Thank you. And the other question was... find my note. Yes, you were asked by Mr. Duncan in the context of the summer of 2019. He drew your attention to a return of concerns, and you replied that, as you remembered, there were further gram-negative infections. Now, you then went on to give what looks like a precise figure, which you attributed to hospital-acquired infections. Is that information that you got from someone else, or is
it comes from the minutes? It gave each minute would give the total number at that time point. So I don't know what the actual total number at the end of that period was. And they did split them into definitely hospital acquired and ones which could have been acquired elsewhere.
So that my fault for not hearing clearly. Where did that information come from?
For me, it came from the minutes, because that's how I was supplied the evidence by control of infection at the minutes, but at the meeting. But that data will be available from microbiology.
Right. Thank you. Now, as I indicated at the beginning of the hearing this morning, and I'm intending that we conclude your evidence this afternoon, Professor, what I'm going to do is rise for 10 minutes, just to allow everyone the opportunity to consider whether there's anything that has arisen which could not reasonably have been anticipated, having regard to the material that was before legal representatives. I'd like to think that we can do it in, if not in 10 minutes, in not much longer than that. Once I get clarification that we've been able to do that, we'll all convene with you, Professor, either to be perhaps asked additional questions or just to confirm that there are no other questions. So I'd ask Mrs. Brown to take you back to the witness room. About 10 minutes, although I appreciate that might be a bit sharp.
Please stand.
No, Mr. Duncan,
I don't understand there to be any further questions, my lord.
could we ask Professor Gibson to rejoin us? Professor Gibson, there will be no further questions. And I'm very glad that we've been able to finish your evidence within one day. You're now free to go, but before you go, can I just thank you for your evidence today, but thank you for all the work that has gone into preparing that evidence. What is very evident is that you have many responsibilities, and I'm very conscious that preparing to give your evidence has no doubt had an impact on the many other things that you have to do. And I repeat my thanks for giving evidence, and it comes to it, I probably owe you even more thanks for preparing to give evidence, but you're now free to go.
Thank you very much.
Now, the timing is such that we will be able to resume tomorrow, but not at 10 o'clock. I understand from Mr. Duncan that we'll be able to take, is it Dr. Chowdhury?
Dr. Chowdhury, my lord.
Dr. Chowdhury, but beginning at 2. So if legal representatives were able to begin at 2 o'clock, that would be very satisfactory. See each other tomorrow afternoon.
Please stand.